Welcome to the Student Faculty Seminar of the Presidential Lecture Series and the Philosophy Forum. It's my pleasure this afternoon to introduce Anel Prim. She is Director of Minority and National Affairs at the American Psychiatric Association and Associate Professor of Psychiatry at Johns Hopkins Medical School. You will get a full account of her many accomplishments this evening when at 8 o'clock in the University Theater she will talk about red, white, black, and blue, race, culture, and mental health in America. Her topic this afternoon is mental health matters for the nation and Montana. Please join me in welcoming Anel.
Good afternoon, everyone, and thank you, Dr. Borgman, for your kind introduction. It's my pleasure to be here in Missoula. I'm glad to know how to pronounce it. I was listening very carefully to people when I arrived at the airport. I thought it was Missoula, and I guess that's my sort of northeast attempt at it, but I understand Missoula is the correct way. Is that right? Okay, thank you for that. This is my first time to Montana, and I must say I've had just a wonderful welcome and really wonderful interaction with students and faculty so far. So I want to thank you all for that, and thank Dr. Drake for inviting me to speak. I'm going to talk today about mental health matters for the nation and for Montana. I think wherever I go, it's very important to try to customize what I talk about to the particular audience, and hence my attempt at doing so, focusing on Montana. First, I'd like to start out with talking about what mental health is. Believe it or not, as a psychiatrist, I've been a psychiatrist now for over 20 years, and it wasn't until a few years ago that I thought about what mental health was. My orientation was so focused on mental illness and on pathology that I didn't stop to think about what mental health was. And I think that's really very important, very telling about the kind of training that I had as a psychiatrist. But nevertheless, former Surgeon General Dr. David Satcher had a report on mental health, which came out in, I think, 2001 or so, and he gave this definition of mental health as the successful performance of mental function throughout the life cycle that results in productive activity, fulfilling relationships, the ability to adapt to change and cope with stress, which is so critically important, and of course, really the foundation for almost everything we do, thinking, communication, learning, emotional growth, resilience, the ability to bounce back from adversity, and self-esteem. So really, what else is there? And then I think it's important to also talk about what mental illness is, and it's not exactly the opposite of mental health, in that mental illnesses are health conditions that are characterized by changes in mood, changes in thinking, and changes in behavior, or some combination of these three things. And really the hallmark of any mental illness is the fact that it's associated with distress and or impaired functioning. And so if you think about the mental illnesses that you're familiar with, they do have all of these characteristics. I'm going to focus most of my comments today on the illness of depression, and which is quite common in our society. This is a medical illness that affects how we think, the way we act, how we feel. And because we use this term depression in common parlance so much, so loosely, I think it loses a lot of its meaning as an illness when we speak of it that way. So just to underscore that point. And when we think about depression as a medical illness, as a disorder, we think about the DSM criteria, which stands for the Diagnostic and Statistical Manual, which is the classification manual that mental health professionals use to identify different mental disorders. And the diagnostic criteria for depression as an illness is to have at least 5 of the symptoms in this list for most of the day, nearly every day, for at least 2 weeks. And they include symptoms which cluster in 3 main areas: in a change in mood, a change in one's self-attitude or sense of self, and also a change in sense of well-being or vital sense. And some of the highlights of this are depressed mood, but many people may also be irritable or experience anxiety, changes in sleep or appetite, either up or down. And I think stereotypically people think of depression causing lack of sleep and low appetite, but they can also go in the other direction, causing increased appetite and weight gain, and also increase in sleep. Certainly changes in concentration and fatigue and so forth can have a significant impact on a person's functioning, whether that be in the workplace or in their roles as a parent or spouse, or even as a student. And of course, the repeated thoughts of death or suicide that many people with depression experience can lead to it becoming a lethal condition. So very important for us to recognize the significance of this illness in our society. And also in the world, depression is one of the leading causes of burden of disease worldwide, and you see where depression sort of sits in this long list of illnesses and other issues. It's really growing as a cause of disability across the world. And in our country, depression, in terms of its lifetime risk, 13 to 16% of Americans will have an episode of depression in their lifetime, any given year, affecting 15 million people. And many people think of depression as a woman's disease because the ratio of people with depression is 2 to 1 in terms of women to men, with 1 in 5 women having an experience of this illness during their lifetimes. Now, I would like to underscore that while this is more predominant in women, depression certainly does occur in men, and some of you may be aware of some national campaigns to raise awareness of the fact that men indeed do get depressed. And there's actually a National Institutes of Mental Health campaign on this, Men in Depression, and also another campaign called Men Get Depression that has a video attached to it attempting to raise awareness about its prevalence in men. Looking across other countries and making comparisons between high, low, and middle income countries, we see that amongst the high income countries, it tends to be a higher rate of depressive disorders. And unipolar basically means the type of depression where a person only gets episodes of depression, as opposed to bipolar disorder, which is characterized by having at least one episode of mania, which, just to simplify it, is like the opposite of depression. So what are some of the risk factors for depression? Certainly female gender, given that we have that predominance of women with depression, having a family history of mood disorders, and we do know that depression tends to run in families. And there are other risk factors such as low socioeconomic status. People who live in poverty have an increased risk for depression. Single marital status, working mothers, people who have difficulty in interpersonal relationships, certain personality characteristics such as shyness, for instance, can increase risk for depression. Being a victim of childhood abuse is another factor, and also recent stressful life events can increase risk for having depression. The real crisis in our country currently is that depression is often under-recognized and under-treated, with only a fraction of people who have the illness being properly diagnosed and treated. And it's very common that we see depression in the primary care setting, and it is often missed in that setting. But I certainly don't want to single out my primary care colleagues, because even in the psychiatric setting and in the mental health setting, depression cases are missed there as well. So we all need to increase our acumen in this regard. People of color are more frequently undiagnosed and undertreated than are Caucasians, with African Americans and Latinos being less likely to receive what is called guideline consistent care for depression, and this has been found in a number of studies. Well, the truth is depression costs our society a great deal every year. Some of the estimates that have been made in the past have been $43 billion a year due to the disability that it causes, the absenteeism, and something called presenteeism, meaning when people show up for work but they're not able to function up to par. Depression is the leading cause of disability, causing just billions of lost days due to physical conditions and mental conditions. Getting back to members of some of the diverse racial and ethnic groups in our country, they are more likely to receive depression care in the primary care setting, if at all. There are lots of reasons for that. Some of the stigma that attends having a mental illness in certain cultural groups, and the fact that they often express symptoms with physical complaints, the idioms of distress, if you will, for depression in some of these cultures are commonly to have aches and pains. Not to say that these are the only groups who experience that, but for instance, changes in sleep and appetite, particularly the appetite changes among African Americans, are among some of the common presenting complaints, and also other idioms of distress that may lead to misinterpretation and misunderstanding of the fact that depression really is present are symptoms like anger and irritability, which in certain vulnerable groups could be regarded as something that would lead to someone being sent to the correctional system as opposed to the health or mental health care system. And interestingly, among African Americans, it's been found that when depression is untreated, it tends to be much more chronic and lasting longer and causing more disability than in other groups. And so when we can recognize and treat depression early, we really do not only the individual, but their family and the community a great service. So what about Montana? When we look at some of the demographics here, we can see that along a number of lines in terms of some of the different ethnic and racial groups, that there are some differences between Montana and the U.S., as you all are probably aware. It has a larger Native American population, a much smaller African American and Asian population, and Hispanic Hispanic population than the general U.S. Census shows. Mental health in Montana, about 33% of Montanan adults reported poor mental health in the last 30 days, and this was about the same as the U.S. On the whole. The source of this is from the Kaiser Family Foundation. And the next series of slides comes from the Center for Disease Control, which looked at the prevalence of serious psychological distress in the past year among adults. And as you can see, Montana is not at the top range. It's in the 11.95 to 12.86 range of states. The states in the red are where the rates of serious psychological distress are higher, in the 12 to 14% range. When we look at serious psychological distress in the past year, this shows again a breakdown according to age group, and we find that the age group that has the most burden in terms of serious psychological distress is in the 18 to 25, the young adult age group. And we see that across the United States, but with a slightly higher percentage of serious psychological distress among residents in this age group in Montana. And having at least one major depressive episode in the past year among those age 18 and older. As you can see, Montana is in the top range, where it varies from 8.68 to 9.38%. And you see some of the company that the state is keeping in terms of this higher rate of major depressive disorder. And it might be interesting to speculate a little bit later what some of your thoughts are about why that might be the case. Looking at depression again, comparing Montana to the U.S. by age group. As you can see, Montana is exceeding the general sort of U.S. average in really all age groups with the red bars. And again, in that 18 to 25 year age group, it seems to be the most vulnerable. And slightly less in those over age 26. But this is certainly not to say that any age group is left untouched when it comes to the disease of depression. I think it's important to note the fact that depression does not usually occur on its own in isolation. It commonly co-occurs with some of the most common chronic diseases. And certainly depression should not be explained away by the existence of other medical conditions as if it was the other condition that caused the depression. Very often depression might have been there in the first place, increasing risk for things like heart disease. And we know that people who have depression who have heart disease have a higher risk of depression, and the same holds vice versa. We see this in diabetes as well. Individuals with diabetes have 2 times the risk of having depression compared to the general population, and the opposite also holds true, that those with depression have twice the risk of diabetes. So very interesting connection between these 2 diseases, such that we should always be thinking about the other disease whenever we see depression or diabetes appear. And here are some of the other medical conditions that are commonly associated with depression: stroke, cancer, fibromyalgia, dementia, coronary artery disease, chronic fatigue syndrome, and HIV. And I could go on with this list. Asthma, arthritis, and other diseases also increase risk of depression. We have another level of co-occurrence with depression that is quite common, and that is with substance abuse. And in fact, almost a third of people being treated in the primary care setting who are diagnosed with depression also reported hazardous drinking, use of illegal drugs, as well as misuse of prescription drugs, which is becoming more and more common in our society. And we know that when depression is untreated, that it can increase risk of substance abuse, something that we often refer to as self-medication. Sometimes when mental health care is not readily available, or if a person is not motivated to seek such care, or feels stigmatized by seeking such care, they may reach for the substances that are close at hand, and in many of our communities, alcohol, illegal drugs, prescription drugs are just all too available and accessible. And so nowadays, you know, it used to be in the old days when I was doing my training in psychiatry that substance abuse and mental illness were very much disconnected from each other. And people who needed one or the other type of care were often sent to the other place and said, you know, people were told, well, we can't treat you until, we can't treat you in substance abuse care until your depression is taken care of. And those who would go to a mental health setting first would be told, we're sorry, we cannot treat your depression until your substance abuse issue is taken care of. I may not have said that just right, but in any way, people were just being told to go to the other place. And hopefully that's changing. I think there's a much greater recognition that more than likely a person who has either substance abuse or a mental illness like depression probably has the other illness on board as well. So we're very conscious of co-occurring disorders and the need to treat them simultaneously if we're going to get good outcomes. Looking at Montana compared to the U.S. population in terms of alcohol dependence or abuse in the past year, as you can see, Montana does exceed the rates of the country pretty much across the board, even in the 12 to 17-year-old age group, 18 to 25, and 26 and above. And with some of my conversations with your colleagues earlier today, you know, I've heard that alcohol continues to be a challenge, and certainly it's not just to Montana, it's really across the nation. And looking at substance abuse treatment in terms of admissions, when we look at all substances of abuse, as you can see, there's a breakdown. 76% are from the Caucasian population, 20% from American Indian, Alaska Native, and 4% from other. And looking again from some very similar percentages with alcohol only. And I think the take-home message for this slide is really looking at the American Indian population and the 20% representation in terms of substance abuse treatment for all substances. That really is overrepresentation compared to their rate in the Montana population, which is 6%. So there are some disparities there in terms of the treatment, and it would be interesting to look at what the needs are versus what the treatment is occurring here. And this is a pattern that we see in other parts of the country with a large Native American population. When we look at the youth risk behavior survey of high school students that occurred in 2007, we see that 26% of Montana high school students felt so sad or hopeless almost every day for 2 weeks or more in a row that they stopped doing some usual activities. And interestingly, the rates were much higher among females compared to males, and perhaps some of that is attributed to depression, which we know is more predominant among women. And again, looking at high school students and comparing those from Montana compared to the U.S., looking at suicide attempts and serious suicidal thoughts. As you can see, some very similar percentages between the U.S. and Montana. But interestingly, when we look at Montana and compare the percentages of males and females, that there is a predominance of females, particularly among those making suicide attempts and actually attempting suicide. We do know that nationally that males tend to have higher rates of dying of suicide, and that women tend to predominate in terms of attempts, and so that is a national pattern. And when we look at Montana's suicide rate, it is among some of the highest rates in the nation, with suicides being 5 times more common in men, again with attempts higher in women, with the highest rate of attempts in the 15 to 19-year-old age group, and in general the highest rates of suicide are among elderly men, and we do see that across the nation. I would like to just to situate the issue of untreated depression and untreated mental illness in the context of what I call a vicious cycle, which really exists in all communities, but is particularly pernicious in communities of color, who are typically underserved in terms of health and mental health needs. But if you can imagine untreated depression, increasing risk of substance abuse through self-medication, which can then contribute to poor physical health, for example, with increasing risk in sexually transmitted infections and worsening of other health problems like heart disease, diabetes, and so forth. And there's really nothing really about a mental illness or substance abuse in and of itself, or a person who would use it, that would increase risk for sexually transmitted infections like HIV, but rather the fact that having a mental illness and using substances impairs one's judgment to the point where they will not make decisions in the same way that they otherwise might if they were not intoxicated and did not have an untreated mental illness. We can also go in the other direction, where having a mental illness and substance abuse on board could certainly increase risk of being a victim of or a perpetrator of violence, of being at risk for being incarcerated or being placed in juvenile detention. This is a big issue, particularly in distressed communities and communities where poverty abounds, and in communities of color where policing is extremely aggressive, and people who have mental health needs or who are abusing substances may not be recognized as such, and be more likely to be considered someone who needs to be in the correctional system, which unfortunately at this point in time is not the ideal place to receive one's mental health care. I think many of you may be aware of the fact that the place where the most people with mental illnesses are right now, or is right now, is in the correctional system. It has replaced the state psychiatric hospital system as the repository, if you will, for people with mental illnesses. Mental illness is very much criminalized in our society. This is a tragedy, and we really must do more to invest in diversionary methods and mental health courts and so forth, that we make sure that people who have mental health needs do not end up inappropriately in the criminal justice system. And of course, upon leaving that system, sort of re-entering the community, there is not often a warm embrace for these people. That's really an understatement, and often very difficult to have one's mental health needs met, or really a number of different needs met after release. And this just contributes to poverty, homelessness, foster care, unemployment, just a host of social ills. And so really, if we could intervene in the center and to treat illnesses like depression and others, perhaps we could prevent some of this cascade of negative consequences to our communities. The truth is that depression is indeed treatable, and 80 to 90% of people with depression eventually respond well to treatment, and almost all individuals gain some relief from their symptoms. And perhaps you all are familiar with the various treatments that are used in depression. Psychotherapy, including talk therapy, is a partnership that's confidential between an individual and a trained professional. Antidepressant medications are used to correct some of the chemical imbalances in the brain that underlie depression, and these medications are not addictive, contrary to popular opinion, and often this is a barrier for people accepting antidepressant treatment. Really, the ideal is to have both, if possible, antidepressant medication and psychotherapy. And of course, there are a number of other measures that are important to employ in care of depression. Certainly understanding one's illness, not only for oneself, but also for the family. Support groups can be extremely helpful. Having the support of friends, family, and others. Prayer for those who have strong spirituality and religious beliefs. Exercise has been shown to be very helpful in ameliorating moderate depression, and some recent studies show that it is good for preventing depression as well. And meditation, relaxation, avoiding excessive caffeine. I'm not about to say that drinking caffeinated beverages is a bad thing, but if used excessively, it can interfere with sleep, which can worsen mood disorders like depression, and it can also increase anxiety, which is a common bedfellow with depression. And certainly avoiding alcohol and drugs, which can worsen a mood disorder like depression. I wanted to mention here something that I learned is in use in Montana, and other parts of the country are trying to catch up to you, and that is the use of telemedicine, where technology is used to connect individuals in need with health and mental health practitioners who are at a different location. This is typically employed in areas where there is a dearth of health and mental health professionals, and I know there are certain parts of the state here and certainly other areas of the country where this is the case, and certain mental health services can be provided through this mechanism: medication review, follow-up visits to monitor progress, discharge planning, even individual and family therapy, emergency consultation, particularly when perhaps a primary care practitioner may be seeing an individual with mental health needs and may be unsure about what to do and may need some decision support. And so reaching out to specialty mental health professionals through telemedicine can be useful. Patient care conferences, employee assistance programs, etc. And there's a website for this, for those of you who are not familiar. And I was pleased to see that the state of Montana spends more on mental health services, at least spent more, and this was the most recent available to me in my office in FY 2005. I don't know how things have changed in the intervening years, but at least at that time, there was more money spent per capita in Montana than in the U.S. on the whole, and much more than some of the neighboring states. I'm not sure if there's anyone here who is familiar with the National Alliance on Mental Illness and their Grading the States, which came out a few years ago. And does anybody know how Montana fared in terms of its grade? A D. Well, as you know, many states around the country received scores around in that range, and I understand that there's going to be another Grading the States coming out to see how all of our states, hopefully there's been some improvement, but this comes at a very difficult time when many state budgets are squeezed, and we're in the midst of an economic crisis, and so we're all bracing for the impact on mental health, and perhaps Montana is no exception for that. But one thing that I'm hoping that we will continue to make progress on is the issue of stigma, or the negative views of mental illness and of people with mental illness that has been very common in our society. I do think that it has changed with organizations like the National Alliance on Mental Illness and Mental Health America and many others. Certainly the stigma that people with a mental illness experience themselves can just entrench them in feeling isolated and alienated from others, rejected and hopeless. Certainly in the family, stigma does hurt people with depression when there's a lack of understanding about how important it is to be supportive of a person with depression. Excuse me. And also, in terms of the societal stigma that we see, that also needs to change. Many of my colleagues at SAMHSA, the Substance Abuse and Mental Health Services Administration, don't even like the word stigma. They recommend that we use the word discrimination against people with mental illness, which is really what this is. So we really need to turn that around. And also to remember that there are certain protective and resilience factors that are at play in our society that probably keep all of us from being depressed or experiencing a mental illness, and we should do our best to, when we can, to invest in these protective factors, which can really serve as a buffer against mental illness. Again, support from family, friends, or health providers, religious involvement for those who are inclined in that way, social participation, neighborhood, community, professional, and other sorts of interests. And some other factors that have been found to be important in resilience is having the power to make decisions during stressful life events, and also having access to material resources that allow people to be able to make choices during tough times. Certainly this is not always the case, and we do what we can in the mental health and health professions to make such resources available to the people that we see. And so in terms of depression, some of the take-home points certainly is a medical condition like hypertension and diabetes. And the hope is that if we could convince people of that, perhaps depression would be treated like or regarded like other illnesses. Certainly it's quite common, runs in families, often co-occurs with a host of illnesses that we see very commonly. It's typically under-recognized, under-treated, and it costs our society and also costs individuals and their families. But the good news is that depression is treatable, that antidepressants are safe and effective medications that are not addictive, and the important message to people out there who may be experiencing illnesses like depression, not to keep it a secret, to get help, let someone know about it so that they can help get the individual some care, and very important to tell your healthcare provider. As a matter of fact, we at the American Psychiatric Association have been promoting the use of a very useful tool called the PHQ-9. That stands for the Patient Health Questionnaire 9. And it is a self-report instrument that measures depression. And many people refer to it as the blood pressure cuff for mental health and psychiatry. There are not many tools that we have in psychiatry to make a quick diagnosis and an objective diagnosis, sort of from a measurement standpoint. And this is it. It's been widely studied and found to be a very good measure of depression across cultures. And it has also, it actually fits exactly with the 9 symptoms of depression that I mentioned earlier in the DSM criteria. And so the hope is that in the primary care setting and in mental health settings, that the PHQ-9 could be used to assist clinicians to make a diagnosis and to get people in treatment if they need that. And so we really do promote the wider use of this scale so that even if we can't prevent depression, at least from a public health standpoint, we could engage in secondary prevention where we recognize it early and help people get treatment so that they can increase the likelihood of leading a happy, healthy life. I'm going to stop there, and just a couple of resources that perhaps you all are familiar with: the Montana Mental Health Association, NAMI Montana, the Department of Public Health and Human Resources that has the Division of Addictive and Mental Disorders, the Montana Advocacy Program. Those were all state-level resources. And here are some resources from my organization, the American Psychiatric Association. And I'd like to call your attention particularly to the healthyminds.org website, which is our consumer-oriented website, which has a lot of wonderful information there, including a parent's med guide for children who experience depression, and some tips there. Other organizations: Depression and Bipolar Support Alliance, Depression is Real campaign, Mental Health America, and the SAMHSA National Crisis Center. Thank you so much for your attention, and I think we have plenty of time for questions and discussion. Thank you very much. So, yes, sir.
Do you have any idea of depression rates in other parts of the world and in other cultures?
Depression, interestingly enough, the rates are rather similar across the world. And there are some differences in China. It's interesting that depending on the criteria that you use, and the point is here, it relates to something I mentioned earlier about the presenting symptoms and the somatization that may occur in terms of people not expressing depression as sadness and so forth, but rather with physical complaints is much more common in other parts of the world, which may result in not actually receiving that diagnosis. And in fact, in the DSM, there is a glossary of what we call cultural bound syndromes that describe a number of culturally mediated conditions which may be very similar to depression, but is really described in a cultural context. I'm trying to think of some examples to give you. One that comes to mind, which is common in Africa, is called brain fag, which is something that students often experience where they have difficulty in concentration and sadness. But when that constellation of symptoms would arise, people wouldn't think about depression as a diagnosis, but rather this cultural bound syndrome. So that's one of the ways that we may see variations across culture in terms of how it's expressed. And interestingly, at the American Psychiatric Association, we're now in the process of developing the criteria for the DSM-5, which is the next edition of the sort of psychiatric disorder classification manual. And there's a lot of attention being paid to looking at the different ways that illnesses like depression and others present in different cultures, and because this is really an international document, and so many researchers are working together to come up with ways of how to make the DSM more useful internationally for making diagnoses. Yes.
How confident can we be of the application of those symptoms and all the statistics that follow from it? There are some critics recently who have said that some depression is just melancholy, which may be a good thing for poets and philosophers. and then, of course, from conservative quarters, you often get the medicalization of ethics, right? So is there general agreement that there is something out there, we can measure it, or is it sort of fuzzy and difficult at the boundaries?
Well, I think at the boundaries it is often fuzzy and difficult, and we do know that many of these illnesses can present in different ways, and so it's hard to know whether you want to make the criteria more stringent so that your diagnoses are more specific, versus making them much broader so that they're more sensitive and you pick up more. And these are the sorts of struggles that the members of the DSM panels are working on right now. They certainly do take great care to do field trials. I mean, there's a lot of research involved in this, but I think that we are going to see perhaps some changes in diagnostic criteria for different illnesses based on some of the feedback that people have gotten over the years since the publication of the last DSM, which was maybe 8-9 years ago or so. But there's no easy answer to that, and I think that we do have to be careful not to over-medicalize symptoms that are quite common in the population. So thank you for raising that. Yes, sir.
From a cultural point of view, considering the fact that 6% of the population in Montana is Native American, 20% are depressed, they're probably represented at least 4-to-1 or 5-to-1 in the correctional system, as people know.
Yes.
Years ago in Navajo, there was no word for depression. Spyro Manson talks about this. So how, DSM 1, 2, 3, and 4, how do you diagnose depression where there's no such word? So even the concept of talking to people about what the symptoms are, the mindset is so different. And the plug I'd just like to put in with that is working with Native American or a different cultural group. It's really important to be able to understand that they really they may not look at the world as we look at the world.
Exactly.
They probably haven't read the DSM.
Well, with the advent of the DSM-4, there was an addition, the cultural formulation, which provides sort of a blueprint for mental health professionals to consider the diagnosis and care of a given individual of any cultural group. And the cultural formulation covers a number of areas: the cultural identity of the person, and under that category could be the language that they use, how they identify themselves, their level of acculturation. The next item is the cultural explanation of the illness. Does the person even see what it is they're experiencing as an illness? And certainly we know that this is mediated by cultural belief. Understanding some of the idioms of distress, whether how people might express difficulty through somatic or bodily complaints, or through anger, irritability, or in other ways. Another dimension of the cultural formulation is the level of psychosocial functioning and how people respond to stress, and sort of the social context in which the individual is. The fourth is the therapeutic relationship, the relationship between the clinician and the individual, and you know, transference issues, countertransference, how what each the practitioner and the patient bring into the therapeutic alliance that may affect how each other is seen, and may have an impact on the progress. And then finally, just an overall sort of assessment and diagnosis and care. I think if people, you know, there are many people who have held the DSM-4 book in their hands and have never seen that cultural formulation or thought to regard it. But when it comes to the care of American Indians or you know, any cultural group, taking the time to think about what are some of the cultural factors that that come into play, and really taking stock of some of the cultural beliefs and practices which may be important to somehow incorporate in one's treatment plan. An example of that is in the Southwest, where you know, there may be sweat houses right next door to a psychiatric hospital, which would allow an individual who has beliefs in traditional healing and the value of them to be able to receive that simultaneously with other sorts of care. And so there are ways that we in the mental health profession can take into account someone's cultural beliefs and integrate that into the care to make the care that we provide more accessible, acceptable, and then also just to make sure that we're educated about how that given individual, what the meaning of the symptoms is within that cultural group. So I think this is very important, and I understand that at the University of Missoula that the trainees here in psychology are getting this kind of exposure to the mental health needs along different cultural lines. So thank you. Yes?
You briefly mentioned that incidence of depression is increasing across the world. I was wondering if you thought that it was from better recognition of the symptoms and the cultural differences of the disease, or if there's something else going on that is actually increasing the occurrence.
Well, I'm not sure if I said quite that point. I mean, I think it has increased over time. It certainly depends on what kind of criteria one uses. Some of the slides that I showed focused on serious psychological distress or poor mental health, which may not actually meet criteria for depressive illness. But I think that, you know, we really have to question how rates of depression are arrived at. There are some studies that are based on individuals who show up in clinical settings. And so naturally, if we are to gauge rates of depression for those settings, they're going to be higher because people sort of self-select who have needs to come for treatment. There are also household surveys that are done, and those give us a much more accurate picture of prevalence, where researchers will go door to door and will actually administer a standardized instrument to determine whatever the mental illness is, depression or otherwise. And so that gives us a more accurate estimate of the prevalence of depression. You know, it may have increased over the past few years, and I'm just thinking, you know, you want to compare apples to apples in terms of the same sorts of surveys. And if I were to speculate as to why there would be increases, I think the sorts of pressures that and stressors that individuals experience, increases in substance abuse could certainly contribute to that. We know that a number of the diverse populations have much higher rates of some of the most common chronic diseases, which are also associated with depression and other mental illnesses. Certainly the economic crisis and poverty, rates of poverty certainly have an impact. These are the things that come to mind as potential sources. Yes?
It seemed like I'm not sure whether it was in the Montana or the national statistics, but it seemed like the rates of reported depression among African Americans was quite a bit lower than Native Americans or white Americans, even though some of the same environmental factors could be high in those groups, like poverty or rates of incarceration. Why do you think that is? Well,
actually, the slide that I showed that had the breakdown of different ethnic and racial groups in Montana, that was just a demographic slide, just census type of percentages. It was not linked to mental disorders in any way. But since you raised the question, we do not see significant differences in rates of depression across the racial and ethnic groups, particularly when you control for socioeconomic status. But where we do see the disparities is in terms of receipt of care, and maybe that's what you were referring to, because we do see much less help seeking among the groups of color, and even when these groups come forward for treatment, they tend not to get the same level of quality of care as do their white counterparts. So this is really where we need to zero in terms of improving clinician training, making sure that they become conscious of perhaps some of their unconscious biases that we know from the Institute of Medicine study Unequal Treatment, that this is one of the sources of disparate care that different racial groups experience. So the take-home message is that the rates of mental illness are relatively the same for these groups, but it's really their receipt of care, their access to care is often a big issue as well, and even some of their outcomes that vary. And so we really need to improve the quality of services that we provide, our knowledge of the needs of these populations, and better communication across cultures. Yes?
So you said that that prisons have become the repositories for the mentally ill, and I think it's 40 years ago that most of the state hospitals were closed, or the mentally ill were closed. And then we went to community mental health, but then community mental health centers lost a lot of funding. I'm curious what your vision is for what on a national scale, what the program ought to look like.
Well, I think we need to make investments in community-based care. I think that is very important. It allows people to be with their families and, to be sort of where they're from, to be close to home, and to have the kind of supports in place. For instance, not all individuals with mental illness can avail themselves effectively of traditional outpatient services, that is, coming to where the practitioner is. Sometimes we have to engage the individual in their community, whether that means seeing them in their homes or in some other setting. And This is called assertive community treatment or mobile treatment. It has different names and has been shown to be very effective in ensuring that people, particularly with severe mental illness, get the care that they need and get the kind of positive outcomes and opportunity to work again. And so I think that needs to be a component, community-based care, assertive community treatment. We need to have care for people with co-occurring mental illness and substance abuse so that people can get those services simultaneously. We need supported employment so that people with mental illness can be in the workforce and realize some of their dreams. Certainly, taking what we call a recovery-oriented approach in mental health, which has been something proposed by SAMHSA, to give people hope that their lives in the community can be good and fulfilling and productive, and to also ensure that people have a say in what they want in terms of their care. And there is a movement afoot to really invest in shared decision-making where it's not such a patriarchal sort of system, but where in making treatment decisions that patients or clients can participate actively in that, and that mental health practitioners would be open and welcoming of the individual's point of view. There have been also some of the other evidence-based sort of approaches involve self-management, where we again give more power to the individual to be able to take care of themselves and to monitor themselves, but also to have the needed supports in place. And I think we cannot afford to absolutely eradicate psychiatric hospitals, because there still needs to be some place where people who are not able to remain in the community can be safely treated. And hopefully with periods of hospitalization being as short as they possibly can. With the notion of sort of keeping people in the least restrictive environment for the least amount of time. So that's what I see. I know we have a long way before we get there, particularly with some of the limitations and resources that the states are now facing. But these sorts of investments can save money in other places. And I think we need to make the case to our legislators that making these kinds of investments can reduce costs associated with the correctional system and the social welfare system and so forth. So I think that sometimes people have been penny wise and pound foolish and have seen that cutting from mental health budgets, will save money right now, but in the end, it ends up driving costs elsewhere. So that's the vision that I see. Yes.
Just out of curiosity, and I may be off base here, I'm wondering if severe PMS or a premenstrual dysphoric disorder are a form of depression.
Well, there certainly are a lot of similarities. Some of the symptoms overlap. Depressed mood, anxiety, maybe feelings of low self-esteem, tearfulness, et cetera. And so I think that when making a diagnosis, in medicine, we have something called the differential diagnosis. Whenever we approach someone with health or mental health needs, and they tell us what their complaints and symptoms are, we start thinking about, well, what could this be? I mean, we don't just say, okay, sadness around the time, just prior to the menstrual cycle. Well, that must be premenstrual dysphoric disorder. We need to rule out other possible explanations for what it is they're presenting. And sometimes we might, we certainly take a history, very careful history. We might administer some screening tests, for instance, the PHQ-9, and then rule out or rule in, one or the other disorders that might be on our list. And then we choose the one that most likely explains what it is we're seeing in terms of the complaints. And so we would really want to be careful in making the distinction between, what might be depression versus premenstrual dysphoric disorder. But interestingly, the treatment might end up being the same anyway, but I think it is an important exercise to arrive at the correct diagnosis and not mislabel people, even if the treatment is the same. But there are many examples, like what you mentioned, where there is considerable symptom overlap between one or another condition. Yes?
Doctor, I'm most excited about what you said early on, your own shift in thinking in psychiatry in general, from illness to health.
Yeah.
What would you say was the genesis of that?
I think reading the Surgeon General's report on mental health was an eye-opener. And the fact that mental health, being an ingredient in overall health. I think in the mental health field and the field of psychiatry, I'll speak for myself. I think I had taken on, we're often regarded as a stepchild, if you will, within the house of medicine. And, you begin to internalize that designation. And once I read the Surgeon General's report and saw what compelling evidence there was for mental health being a critical ingredient in overall health, that made me realize, just how important mental health was, in the house of medicine, if you will, and that we really needed to, just be strong proponents of putting mental health out there on the table, and making sure it was known that it's just really indispensable as it relates to all of the other specialties and disorders. And it really also is a part of seeing mental health in a public health context, that you can't have physical health without the mental health. And ever since then, I've been, very focused on looking at some of the co-occurring issues, how mental illnesses like depression, for instance, co-occur with so many other different diseases, and really needs to be a component in almost every kind of care that is delivered in healthcare settings. And so this involves people in the mental health field educating others about that, educating not only those in the primary care sector, but those in cardiology and obstetrics and gynecology and surgery and so on and so forth, because it became very clear that let's say someone with diabetes who also has depression, the depression goes unrecognized. The person with diabetes has difficulty managing their illness, following a treatment plan, following a diet, exercise, etc. and begins to deteriorate. And, diabetes is a multi-system disease. It can affect, the heart and the circulatory system. It can affect the nerves. It can affect the eyes, the kidneys. Getting back to the nerves and the circulatory system, it can result in people, actually having amputations. And so, when I started to think about it in that context, it made me realize that, if we don't intervene early in recognizing people's mental health needs who also have other chronic diseases, then they run the risk of having, just terrible outcomes, not to mention premature mortality. So this really put mental health and mental illness at the top of the list of what needs to be attended to in health in general. And so I think that's a big part of it, but also on the prevention end, taking the public health approach. And, particularly for some of the more vulnerable populations, our public health actions could prevent them from getting caught up in that vicious cycle. If we, invest our energies and efforts in identifying mental illness early, screening for it when we can, and when people experience, significant trauma and loss, that we don't wait for people to get sick after that we intervene as early as possible with supports, with counseling, with resources, so as to forestall or even prevent the expression of illness, particularly in vulnerable people. And so, I think our healthcare system is really designed for treating illnesses and not preventing them. And certainly that's how I was trained as a physician and a psychiatrist. So it requires some re-education, and certainly my public health background has helped me in this regard. But I think those are some of the ingredients in what has changed my thinking, and also to stop acting as if it's only the people who have an actual DSM-4 diagnosis who are suffering. There are those people who come into our clinics, hospitals, and offices and so forth who have needs, who may be diagnosed and treated, but there are always many, many more people out there who we never see who have unmet needs. They may not meet criteria for an actual illness, but they may be having experiencing some negative impacts, if you will, on their mental health. And they too are suffering, they too need support so that the psychological distress that they may experience or the poor mental health they may report does not get worse. And so it doesn't mean that we're sort of writing ourselves out of having business if we do this, but there's other business with a slightly different focus, but I still, I think that it is still just as important and certainly more rewarding if we can reduce morbidity and mortality, if we can maximize functioning and wellness and well-being. I think that's what we need to be moving towards in order to have a more overall healthy society. Yes?
I see a lot of value in the medicalization of disorders, but I'm also thinking about there being a number of pitfalls with that. And I'm just wondering, is there a difference between a medical illness and a psychological disorder? And how do you distinguish the two, perhaps?
Well, illnesses and disorders, for the sake of this conversation, I equate those two, and I think of them as being made up of a cluster of symptoms. And I'm wondering if your question relates to distinguishing between psychological distress, for instance, and a psychological disorder or a mental illness. I do see those as different, and if we use the DSM-4 as, you know, our book for making that distinction, the people who might have psychological distress will have some symptoms, perhaps even on the list for depression, like what I showed earlier from the diagnostic criteria of depressive illness. But they just, instead of having 5 or more of those symptoms from that list, maybe they have 2. And so with those 2 symptoms, you know, we really can't make a diagnosis of major depression, but yet and still, you know, if that person is experiencing 2 out of 9 symptoms, and it's happening every day and, you know, most of the day for more than 2 weeks, I mean, they haven't met the DSM criteria, but they've got something going on that, that needs our attention. So, you know, maybe at the end of the day, it's not so different. You know, it may be different when it comes to, you know, having the care paid for by insurance or not. That's one big difference, which is unfortunate. But, you know, that person who is suffering could benefit, you know, from some support, some counseling, perhaps even some psychotherapy, even though their cluster of symptoms is rather small and doesn't meet criteria. And so I think we are aware of the fact that there are people out there with subclinical syndromes, and we use our clinical judgment about, you know, whether they require treatment or not. Even in the even in the PHQ-9. Depending on the score that a person gets, you know, they may get a diagnosis of sort of mild depression, for instance, and might benefit, you know, from some counseling or what we call watchful waiting, so that at least we are paying attention to that person and being mindful of the potential that their symptomatology could get worse, or there could be more symptoms added, which would take them out of the subclinical zone into a clinical zone. But I think the point is really listening to what people complain of and monitoring them over time, and not just writing them off because, you know, they don't meet the criteria of a certain diagnosis or don't have a score. Because, you know, I think at any given time we need to have a holistic appreciation of the individual, looking at their symptoms, looking at their story, you know, looking at the context in which they are living, you know, whether it's culturally, societally, professionally, you know, within the family. All of those things need to be taken into account as we make our judgments about what should we do, you know, to help this person reduce their suffering. Yes.
We recently learned that last year in Missoula County, 29 people completed suicide, which is way higher than the national rate, even higher than the rate in Montana. And in addition to all of the, what I would call preventive and kind of targeted and focused ways of looking at depression differently that you've already reviewed, are you aware of communities that have sort of had a big focus on how to deal with that kind of suicide rate, and what kinds of things have they done in addition to this?
One person is coming to mind, and Dr. Dale Walker, who is a psychiatrist. He's American Indian and has gotten some big grants from SAMHSA to work in Native American communities around the country. And he takes an approach with his colleagues, a real community-based approach, which invests in some of the protective factors that exist within communities, that really focus on some of the cultural issues that one of the other members in the audience spoke to earlier. I wish I could go into more detail about that, but I think that Dr. Walker is someone who you might want to talk to about that. There have been some other suicide prevention programs, actually in my home state of Maryland, a very successful reduction in suicide among young males, and I'm trying to think of the individual who led those, Henry Westray, and actually an award-winning program that he designed. So those are two leads. I'm not sure if you've seen the Surgeon General's report. I think it actually predated the report on mental health, but there was a suicide prevention guidelines. I think it was released in 1999 that I think still has some relevance. So,
Thank you.
You're welcome. Yes.
What are your feelings on electric shock to treat depression?
Well, I regard electroconvulsive therapy or shock treatment as a very effective mode of treatment for depression, particularly for people who are unable to tolerate antidepressant medication, especially among the elderly, if they might have health conditions which preclude their treatment with certain antidepressants, or when the depression is so severe and the risk of suicide so high that there needs to be an intervention that works fairly quickly. I know some of the societal concerns about shock treatment. It really is safe. There are some side effects. People do experience memory loss in association with it, which is difficult to deal with, but it is something that we have in our toolbox to use, especially in emergency situations. I think that is the last question, and I'll be happy to answer others after the session is over. But thank you very much for your attention.